cardiovascular system. And if you follow along, highlight what you want to do. I'm on page 483 in your book now. Okay. So chapter 37 is where we're just going to jump in and start. You what?
Oh,
In your book?
no, printed a slide that would miss the 37th one.
Actually. Hold on. Slides, I want to put it over here. Okay, so 37. So cardiovascular system is more than just blood flow. Okay, this is what have you guys learned about the cardiovascular system so far? Did you go over the circulation?
Yes.
Blood flow, okay. So the primary responsibility of the cardiac system is what?
Blood circulation.
Blood to the body.
Circulation.
More than just blood to the body, more specifically. Yeah, oxygenation. Basically, the blood is going to transport nutrients and their oxygen, nutrients through the whole body, right? Cardiovascular system is going to do that. It's going to feed those cells, transport that nourished blood to the body, and it's also going to absorb waste products. So we're feeding the body with our circulation, and we're absorbing waste products. It's kind of it's more than just blood flow. And again, so we talked about respiratory. Cardiac and respiratory go hand in hand. If you think about the circulation of the blood, right? That blood's
Goes to the
coming
lung.
into the right side of the heart. It goes down into the atrium, ventricle, into the lungs, where gas exchange is taking place, and
Back
the blood
into
comes
the left.
back to, yes, to the left side of the heart, where the oxygenated blood then goes out to the body. So it feeds the cells, it nourishes the cells, it circulates, and then it gets rid of waste and comes back and does it all over again. So it's nourishing the body with that oxygenated blood, and it's removing waste. So that's how it works with the lungs. It's also working with the kidneys. So now you got to throw in kidneys here. Kidneys are a huge, huge component of blood pressure. Okay. Kidneys are also a component of removing waste from the body, right? We know the kidneys are responsible for excretion. So now you're throwing in heart, lungs, and kidney. They all work together. Yeah, like you think about congestive heart failure too. Those people that are retaining fluid, their kidneys are not eliminating them. So that's when we'll get into diuretics later. So all these meds are going to go hand in hand. Cardio, respiratory, and then throw in the kidneys. So again, essentially, the cardiovascular system delivers nutrients and it removes waste. In short, right? The simplified way I can put it is that it delivers the nutrients and it removes waste from the body. Okay? So I'm not going to go through the specific circulation. You guys can do that on your own. But we're going to jump to heart failure. Okay? There is chronic heart failure. There is acute heart failure. So the heart is a muscle. Okay? What happens with heart failure, that the heart gets weak and it gets enlarged. And you might think, well, if it's a muscle, you want it to be large, right?
No.
Not in the case of a heart. You do not. When a heart enlarges, it kind of gets floppy. Hearts need to be normal in size, very compact, very efficient, right? So when the heart gets weak, it kind of gets floppy, it enlarges, and it doesn't have it efficient, which is kind of pumping along, where you want the pump to really be pumping and be efficient. So when you hear like somebody's got an enlarged heart, that is not a good thing. It's very weak. Okay, so it does not have that ability to efficiently pump that blood through the body. Okay, so then the lungs and periphery become congested. So think about the role, think about what's going on, and if lungs and periphery are congested, it kind of tells you what's going on. Is it right-sided heart issue? Is it a left-sided heart issue? Because you know the blood comes from the body to the right side of the heart, right? So if the right side of the heart is congested, or I'm sorry, your periphery efficiently pumping through, it's backing up. And that's how they might get, the ankle edema or the hands or ankle. It's backing up into the periphery because that right side is not pushing it through. Same thing when you hear those patients with, when you listen to their lungs and they sound congested and heart failure, it's probably going to be the left side of their heart because it comes through the right side, goes through the lungs, and when it comes back to the left side, instead of efficiently going to the body, it backs up into the lungs. So that's why, and I'm not going to, you don't need to know very specifically right and left, but just know that there's reasons why you have edema or why when you listen to a patient with heart failure, they might sound like they have wet lungs. They do, because things are backing up and those fluids are building up and kind of getting stuck there, okay? So you have to be familiar with at least the flow of blood circulation and why that's happening. So it is a very real thing, okay? So with heart failure, there's medications we can use to treat it. But again, let's talk about non-pharmacological approaches before pharmacological approaches, okay? So look at your 485. There's some things we can do. Limit salt intake to 2 grams a day. That equals about 1 teaspoon. Think that's a lot of salt or not? 1 teaspoon of salt a day. Tell patients to limit it to 1 teaspoon. I will eat a teaspoon of salt in I eat salt plain. I pour salt.
That's nasty.
That's what I do. My body craves it. That's what it's telling me it needs. 1 teaspoon of salt a day is not much salt in the grand scheme of things, right?
Especially after all the canned foods and everything.
Canned foods, canned vegetables. They're so healthy, but are they? Look at canned foods sometimes. You'll see some, or soups or things like that. Yes, and now they have labels. Oh, low sodium. Oh, what low sodium? What was going on with the sodium before this? Like, oh crap. Canned stuff has a ton of sodium. They use that to preserve canned stuff. So there's hidden sodium too. So 1 teaspoon a day. It's pretty important. Why are we limiting salt intake? How's that going to help heart failure?
The sodium.
Right. Where sodium goes, water follows, right? So the more sodium we take in, the more we retain the water. So where sodium goes, water follows. We eat extra sodium, that fluids that's going to stay in our body with that sodium. And also, where sodium goes, potassium also follows. So now when we start talking about cardiac stuff, sodium and potassium are going to come into play. And when we get to the diuretics, pay attention that there's going to be potassium wasting, potassium sparing. So cardiac is super important to start understanding how these meds will work in the body. It's going to play a big role with how we deal with cardiac patients and how we keep that heart pumping efficiently. It's not as complicated as it sounds, but our body is pretty, it's pretty efficient normally. And if we follow these principles with the sodium and the potassium and the fluids, we can help it just a little bit. Okay, alcohol. Hang it with the alcohol again. Alcohol should be either decreased to 1 drink per day or just avoid it. Okay? Excessive alcohol can lead to, do you guys know what cardiomyopathy means?
Isn't that something to do with the actual muscles in the heart?
Yeah, and basically it's in general terms it's an enlarged heart. And what we know about enlarged hearts, it's not good, it's weak, it's not efficient. Cardiomyopathy? Yeah, well, yes. So essentially, yes, they're both enlarged, but for different reasons. But yes, in essence, yep, enlarged. Let's see, what else can we do non-pharm? There's a lot of things we can do non-pharmacologically, you guys. There's a lot. Sometimes they may restrict the fluid. So if you haven't worked with patients yet, you might. Patients that are on fluid restrictions, you see that sometimes with patients with either heart failure and or kidney dysfunction, because kidneys are responsible for excretion and regulation of blood pressure. It is not just the heart regulating blood pressure. Kidneys are actually a big part of regulating blood pressure. And again, we'll talk more when we get to some of those meds. I think if you look at those tip sheets I gave you, I think it's gonna help you. Just sit down and absorb this. Again, I've laid it out and put it in little points, and I think it will help you, pull it together a little bit, but do one piece at a time, okay? Just do one piece at a time. Let's see, fluid could be, smoking, what? Smoking. Dang it, smoking's not good for anybody, don't do it. It deprives the heart of oxygen. If we're already having a circulation issue, we already have an inefficiency with the heart, we don't need to add smoking and deprive it of oxygen on top of it, which is also going to affect the lungs, which is also going to affect your oxygenation, and so on and so forth. See why we should just be healthy and let's all just be perfect. And because on top of this, we should probably decrease our saturated fats, which we know those are the best fats out there. That's what they said. What's the difference between saturated fats and unsaturated fats?
The ones that clog the arteries versus the ones that don't clog.
Right. So how would you know just looking at something?
Well,
Bacon.
room temperature, that's at room temperature.
That's exactly right.
Right.
Think about your bacon grease. I love bacon. I eat it. I'm all in all healthy, but I'm telling y'all right now, don't mess with me with bacon. Like, I will eat a whole freaking pound of bacon. Like, I'll do it. I will do it. I'll pay for it, but I'll do it. But the grease, as it dries, it gets hard at room temperature, and then I feel guilty. I eat all the bacon, and then I come back later with the pan sitting there like, all that's in my arteries right now, clogging up my. I could die right now because it's clogging up. So if it hardens at room temperature, like bacon grease, it's saturated, and that's just a very simple, generic way of looking at it. But like cooking oils, like your canola oils, they don't harden; they just stay liquid. So I'm not saying they're great, but they're better than saturated
What
fat.
about coconut oil?
Coconut oil,
For you, but
it's better. It's good for you in moderation. I got on that coconut oil ban for a while too. I was like, I'm doing everything.
Well, I think the other day it was recommended, I don't know by who, to take like 3 teaspoons of coconut oil a day.
You can just cook with it, or like I put it on my skin. I'm not crazy over that until I get to these kids. Oh, my skin slathering it. But it is good. It's a healthy fat. But again, even healthy fats, you gotta be careful. Like everything
Still a
in
fat.
moderation. It's still fat. Yeah. So, but coconut oil, yes, it is one of the better fats. Avocado oil is one of the better fats. So, but still in moderation. It's still better than bacon fat. So, yeah, but coconut oil, avocado oil, those good fats. And labels are, have patience. They need to learn to read labels. All labels will tell you percentage of your daily intake. Like when you,
They should teach it better for kids in school though.
Do what?
They should teach it better for kids in school though, and maybe they'll
I don't
do
know
it
what they're
more.
doing in school. I would imagine they're teaching it in school now, but I don't know. They might be worried about other things in school right now, like
I don't feel like they teach as much as they used
But
to.
anyway, I don't. I don't know what they're teaching, but yes, you're correct. If you start children at the right age, teaching them the right thing, they're going to develop those habits. But adults, you guys, we all know this. We're all adults. It's hard to break habits of adults, especially if they're lifelong habits. But there's things like ice cream. You can look at ice cream labels. Some of those little pints of ice cream, like that's actually like 3 or 4 servings, and like it's great. Read labels. We should teach our patient to read labels that they might in one sitting take in, I don't know, 110% of saturated fat intake per day. Like that's crazy. So people need to read labels, specifically the sodium and the fat intake is when they're dealing with cardiac issues. It does make a difference. Okay. Some other non-pharmacological approaches, mild exercise. I want to be clear on that. Walking, bicycling, whatever. Exercise for, people with, especially if they're already in heart failure, that's individualized. You cannot expect everybody to be able to do the same thing all the time. Somebody in heart failure, go ahead and run 3 miles a day and get that heart shape. Or you can try that and drop dead of a heart attack, right? So it's very individualized. So the exercise needs to be what that patient can tolerate, okay? So for a person with whether it be chronic or acute heart failure versus a person that has very healthy, high functioning, it's not the same. So exercise needs to be tailored to the individual. Walking is typically the best. You know, that's probably the safest bet. Even running, even for the fit people, running is very hard. Any runners in here? It's hard on the body. It'll catch up to you later.
What, running?
Yes, it will. Yep.
I was running part of the knees, but I like to.
I've got a friend, she does marathons all the time. I'm like, well, yeah, that's fine and good, but you know, talk to me in 20 years, you're gonna be so beat down and hurting and painful because it is just such impact on your body. But it's good for the heart. You're gonna have a great heart, but you're gonna be hurting everywhere else. So, but there's things you can do. Walking is one of the best exercises. You can even walk faster, and that's still better than running. The goal is to get your heart pumping and condition your heart. So whatever that looks like, maybe it's a bicycle for somebody, or you know, whatever the case may be, but it has to be tailored to the individual, and the goal is to get their heart rate up to work it just enough to where they're not killing themselves. Okay, so exercise, whatever it looks like for that patient, is what they need to do. So the whole cardiac arena is just very. It should be time consuming if providers are doing it the right way. I don't need you guys to know the stages of heart failure. You don't need to worry about that here. But the goals of therapy for heart failure is we don't want it to get worse, right? So let's delay that progression of it. Let's maintain that output, the cardiac output, meaning the pumping, functioning of it. Improve the symptoms. If they're having shortness of breath or, edema or whatever their symptoms are, we want to improve that, and the goal is to help them live longer, whatever that looks like for them, and improve their quality of life, which is where medications may have to come into play. Okay. Yes, we already talked about this. I don't need you to know the lab values. I think that's kind of too much for you guys right now. Okay. So we try all these non-pharmacological measures. They may still need medications, but that doesn't mean just because they start taking medications doesn't mean we stop the non-pharmacological measures. Because people, give me a pill, fix it, we'll be good. No, you should still instruct patients to do their non-pharmacological measures. Okay. So one of the medications we can use is digoxin. Have you guys heard of that? Digitalis is your generic name, digoxin is the brand name. So it's been around for a while. It's kind of one of the oldest drugs we have out there. And you guys can follow along in the book. This is one of those interesting things. It comes from the white foxglove plant. So it's a powerful drug. It comes from a plant, so this is where you gotta be thinking about your CAM therapies and medications, right? They can interact. To know what your patients are on. So it actually comes from a plant. So natural does not always mean safer, right? So when patients, like I said, when they flip over to needing medication, some of the CAM therapies need to maybe go away, or make sure it's not a therapy that they're going to be interacting with the actual drug that we've created, right? But the actual plant themselves can be poisonous, which is crazy. So there's a lot of plants out there that in and of themselves can be poisonous, and then we convert them into drugs and take them, and then now they're saving us.
High toxicity.
Crazy, right? So yeah, digoxin is one of those, digitalis. So it's all very interesting, the CAM stuff. Like for those people that know all these herbs and like it's pretty impressive. But again, just don't underestimate the risk of CAM therapies and medications. When they get to the point where they need prescribed medications, we need to maybe talk about removing some of those CAM therapies for their safety, okay? So the digoxin has become pretty effective in treating heart failure. You're going to see different terms out there. It used to always be called congestive heart failure. You are still going to see that term out there. It's not wrong, but the most up-to-date term is just heart failure. So before we used to say congestive heart failure, talking about left-sided heart failure. They just kind of lump it all in one now. heart failure. So again, when that heart muscle weakens and enlarges, it just does not become effective in pumping that blood efficiently, right? The heart rate is probably going to go higher. Why is our heart rate going to be higher?
Because it's pumping harder.
Yeah, and it's like it's working, trying to work harder, so it's pumping faster. Whereas when you have a healthy heart, one pump is efficient. So you might have one pump. This is a nice healthy heart with your, so it's faster. So digoxin is actually going to slow the heart rate down and work on the muscle contractility. So what it's going to do is slow it down and help that muscle be more efficient every time it pumps. So that being said, knowing that it's going to slow the heart rate, become more efficient, what's the risk of this medication? Yes. Anything we can do with the medication, we can go too far with it, right? So the main risk of your digoxin is bradycardia, right? So you're going to hear that now and forevermore. Digitalis, you're going to see it everywhere on every test. You're going to see it on the boards. So what we know is that it lowers the heart rate. But what we also know, just a steadfast rule with digoxin. A common rule that is just standard. If that heart rate is less than 60, we're not giving that medication, right? So when it's time for them to take digoxin,
Check
if
with
we're giving it to them, if they're taking it, the heart rate needs to be checked. How are we going to check that heart rate? If you guys learn about an apical heart rate, you will check the apical heart rate for 1 full minute. Not 15 seconds and multiply times 4, not 30 seconds multiply times 2. You're going to listen to it for 1 full minute. Why?
So we get the full amount.
Yes, another reason too that sometimes a dig is given for is for irregular heart rates. So they might have an irregular heart rate. So if you're checking here or here for 15 seconds, you may get it in the fast or slow phase of it. So you take your stethoscope, put it on the heart, and you listen for 1 full minute, because it could also be irregular. If it is less than 60, do not give that digoxin. So you check that heart rate every time you're going to give digoxin to a patient. You check that heart rate then. You don't want your vitals from your aids from 4 hours ago. That's not appropriate. Check it. If it's less than 60, they're not getting the medication. That's just the way it is. If our heart rate goes too low, what's going to happen? Yes, that's the worst. So you absolutely, that's non-negotiable. Apical heart rate, 1 full minute, less than 60, you don't give it. So heart failure too. There's different causes of heart failure, which we're going to get into later. All this stuff, you guys, when you start looking, you're like, oh my God, there's stuff all over. It all actually comes back together and it's all intertwined. It looks a lot, but as you start looking through the stuff, you're going to start seeing, okay, this is all kind of connected. When we start talking about medications, you're going to see it from one area, for hypertension, for heart failure. You're going to see all these meds interconnect because it is also interwoven. But heart failure, why do they have heart failure? Well, high blood pressure can actually lead to heart failure. Do you guys know what an MI is?
Heart attack?
Right. Myocardial infarction, which means heart attack, right? So, chronic hypertension can cause heart failure. Heart attack can actually cause heart failure. Coronary artery disease, all those arteries get clogged up with stuff, that can cause heart failure. You can have damage to your valves, or disease of the valve. You remember there's 4 different valves within your heart chambers. So that can cause heart failure. Congenital heart disease, meaning
Infants.
we're just born with something, unfortunately that happens. Congenital heart disease, sometimes we find it when people are babies, when they're kids. Sometimes people don't discover congenital heart disease until they're well into their adulthood and discover, oh gosh, here we have this congenital problem all along. And then arterial sclerosis, that's plaque building up inside the arteries. So you can see there's many different causes of heart failure. Doesn't matter what the cause of heart failure is. But it not gonna treat the heart failure itself, similar, but the cause does matter. And, you know, hypertension, well, if we know it's hypertension, that's the cause, we might need to address the blood pressure and make sure we're getting on the right blood pressure medication if it's a hypertension. If it's a, you know, arteriosclerosis, plaques, maybe it's an issue with lipids building up. Now maybe we need to add something to decrease the lipids. So the cause is important. Now a lot of the treatments might look the same, but the cause is important, the underlying cause. So again, this goes into left to right sided. You guys can read through that yourself. So let's see. So I've already mentioned the first naturally occurring glycosides are found in plants. Let's see. So have you guys learned anything about the sodium potassium? Yes.
Yeah.
I don't know how deep I want to go into it with you. Like I said, where sodium goes, water follows, but also sodium and potassium are going to go hand in hand too. So potassium now is very important for the functioning of the heart. Too much potassium or too little potassium can absolutely cause cardiac arrest. So you have to be careful about potassium levels in our body. Now I want to say this now and I'll say it again. Do not get confused between potassium and vitamin K. The symbol for potassium is K in the little plus, right? That's potassium. Vitamin K. So a lot of people start looking at vitamin K and get them mixed up. It's not the same, but that big capital K gets people mixed up. Okay? Do what? Yeah, K plus, that's potassium. Vitamin K is vitamin K. Two different things. We'll talk more later, okay? But yeah, so like if you see labs or things like that, you see people, oh my gosh, their potassium's really high or really low. That's a big deal. When they call it potassium critical high or critical low, that is a big deal because that can affect their heart and they can die. Okay, so if they have too much potassium, we need to get it low. If they don't have enough, we better pump it in them. Potassium is essential for survival of the cardiac muscle. Okay, and again, you guys can read a little bit 486. Top of 486 tells us a little bit about the sodium and potassium pump. But still on digoxin, that's kind of, again, we use it to treat heart failure. It can be first or it can be second line. Typically, it's going to be a second drug that we use. Typically, the first line drugs for heart failure, first line, that means like maybe they're first discovering heart failure. It could be, they could be in acute phase. They might do some IV medications. And again, we'll talk more about that when we get to heart, those drugs. But diuretics, what is a diuretic?
Makes you pee.
What?
Make you pee.
It takes excess fluids off your body, right? So here's the thing about blood pressure. Blood pressure and volume are directly related.
Because your kidneys release the aldosterone and
angiotensin converting enzyme ACE,
which happens when your blood pressure is reacting, right?
It does, yes. And when we get to the diuretics, we'll talk more about it. But for the moment, know that volume and blood pressure are directly related. So if you take in all this excess sodium, and then that causes the fluids to be retained in your body, you have excess fluid in your body, what's going to happen to your blood pressure? It's going to be a chronic hypertension, can lead to heart failure. Therefore, we need to know that it's important to get the excess fluid off. Let's lower the blood end up dying from that. So it has to be addressed, okay? That sometimes that's acute, sometimes it's chronic. 8-year-old fib, 8-year-old flutter, like look at that, you're gonna have 200 beats a minute. How long do you think somebody can go on, an adult, with 200 beats a minute?
Sure. Yeah.
It's not gonna last long, they're gonna die, okay? The heart cannot sustain that. And we're just talking adults here, we're not even gonna mess with kids right now, until next semester, with a whole nother, we get their monitor text, like, oh my god, your patient's heart rate is 200. We know that, that's why they're here. They're a baby, it's fine, so they freak out down there watching that monitor, like, we're just waiting for, like, no, it's okay, babies and adults, they're different, it's gonna be okay, but an adult, 200 or more beats a minute, and the adult will feel it. I don't know if anybody's ever dealt with. Yeah, it's very fast and it is unnerving for the patient, so it has to be corrected for sure. So sometimes we might use digoxin to kind of they call that convert that 8-year-old fib. That just means put it back into the regular rhythm. Okay, so they might try digoxin sometimes. It'll slow it down, stabilize it, steady it, and it usually is pretty effective with atrial fibrillation. But then they might throw other stuff in there, which we'll talk about later, like a blood thinner, warfarin, to keep the blood flowing. Because we also need to think about that too. What is the cause here? Are they getting blood clots? We might have to throw in blood thinners here, right? So like there's just all kinds of stuff that we're going to throw in there. So if you look at digoxin on 486, it does a decent job of laying out the pharmacological data. Okay, so there's your pharmacokinetics of it. Kidney dysfunction can affect the excretion of digoxin. Again, your kidneys and heart work together. So if they have kidney dysfunction, well, crap. Now we're going to have to get them on some kind of medication to treat their kidney issue so that we can excrete the digoxin. Because we do not want a patient to have digoxin toxicity, okay? So that's the other thing you worry about with digoxin. You worry about the bradycardia, and now we throw in toxicity. They could die, okay? So patients on DIG and nurses giving patients DIG have to be very much aware of signs of toxicity of digoxin. So going back, kidney function can affect the excretion of digoxin. Why does that matter with DIG toxicity? If the kidneys aren't excreting it,
Because you're gonna hold it in, your therapeutic level's gonna be hit quicker.
correct. So that's where kidneys are super important with all things cardiac, but now we're talking digitalis. We need them to excrete what it's not using. If they become toxic, so this is a tricky one. So I always use like phone nursing, you know. People call offices all the time. I'm, not, we'll just say it's, there's GI bugs going around, everybody's been sick, right? Don't get caught up if you're ever that nurse on the phone, getting that call, well, I feel terrible, I'm vomiting, I'm diarrhea, I feel horrible. Don't just assume that they got the GI bug everybody else has going on, right? And this is why I did phone nursing for a while. I'm like, I'm out. I'm not doing this because I don't know these people and I am not giving them. So doctors like, my God, you're making everybody come in. Yes, I am, because I'm not taking a chance on that. If you don't know this patient you're talking to, we get it on the unit like all hours of the night. Man, like if I don't know who I'm talking to and I don't know the patient, I can't really give you medical advice because we could get caught up having vomiting, diarrhea. Okay, just increase your fluid intake. Increase this, increase that. If you don't know the background of this patient, that maybe they have heart failure, that they take digitalis, what they may be describing to you is digitalis toxicity, and you just assume because of vomiting and diarrhea, it must be a GI bug, so increase your fluids. Not a good idea. So I just caution you that if you're ever one of those patients wanting advice, and I'm not saying I'm not going to help you and give you advice. I need to know more about you. I need to know the history of this. Are you on, and standard question, do you take any medications for anything?
Any recent health
Then
change?
it starts unfolding like, oh, whoa, drawn, you can get levels drawn in the blood to see if they're toxic. So be aware of these signs and symptoms. The anorexia, vomiting, diarrhea, those green or yellow halos. When they look, they see these little green, they might, my vision, there's something funny, if they describe something green or yellow or just little circles running around. Bradycardia, we know, can just happen. PVCs, premature ventricular contractions, you're not going to know that until they're on a monitor. If they're in the hospital and you see PVCs, you're not going to know that just by looking at them. And then dysrhythmias, okay? So, you get a patient reporting these and you discover they take DIG, they need to have the serum
So then
levels
after
drawn.
the serum levels, is that when you would give them like the digiband and stuff?
It just depends on what their levels are. Is this a DIG toxicity or is it something else going on? So possibly, yeah. So we need to get more information. We have so be very, very careful with DIG and know those potential side effects and the toxicity effects. And then when we talk later about there's other drugs that actually can interact and cause DIG toxicity, other cardiac drugs, which are I think I put that on some of the sheets for you guys. And I don't know about you, for me color coding helps. I try to color code and do different fonts. I don't know, I'm trying to lay it out for you the best I can. It's like cardiac, you guys, cardiology alone, that should be a year in and of itself. So to try to condense all this,
From a
it's a lot.
16 to an 8.
Do what?
From a 16-week course to an 8-week course.
I mean, that's a couple weeks. 8, we're talking like a week and a half.
Yeah.
Don't week and a half. But yes, I get what you're saying. It's a lot. So we are going to do our very best to get it down for you guys, like I said, next week. But I need you to do your part. I need you to do your drug cards, and I need you to review those tip sheets so that as I pull it together, we can do this. Okay? So, no, absolutely, pulse rate less than what?
60.
What you gonna do? You're gonna hold it for
Apical.
sure. Yes, apical pulse less than 6, you're gonna hold it, you might notify the provider or whatever. But then you also need to be aware, are they having any other signs and symptoms, okay, of that toxicity. Super, super important. And there's gonna be some drug interactions. Oh gosh, darn it, sorry about this page numbers. But you guys can find it in your page. So there are some drug interactions with it. Look at that. Diuretics, which we're going to talk about later. Cortisone can cause sodium retention. We don't like that. Antacids. Oh, what do we know about antacids?
Don't take them with anything.
Well, number one, antacids are over the counter, right? So antacids decrease the absorption of it, so it's not going to be real effective if they're taking it at the same time they take antacids. So guess what, guys? Patients on digoxin and they're at home having heartburn. We don't know if they go to the drugstore and get an antacid for their heart. We don't know this stuff, right? So patient education is so very important with stuff. Like we're talking the heart. They gotta have the heart to live, right? So it's super important. These little things are important to know. So maybe you give a patient that takes DIG and come back, well, it doesn't seem to be working. It doesn't seem to be working. We might need to do a little investigation. And we might find out they've been having heartburn and taking antacids and taking it at the same time. So it's these little nuances we need to know about. And again, gosh, diuretics. This is like your heart failure. They might be taking both of these for heart failure. So we'll talk about that when we get to the diuretics as to what can happen. But diuretics alone can cause hypokalemia, which loses potassium. So the interaction here, and we'll talk more later, they can cause hypokalemia. That's low potassium, okay? Low potassium can actually cause DIG toxicity. So the interaction works in that the diuretic is making us lose potassium, right? And then that low potassium causes us to become toxic. So we'll talk about when we get, there's different diuretics we could use that is not going to cause those tip sheets, if you look at that, pay attention to that. There's potassium wasting, there's potassium sparing diuretics. So then we're gonna have to choose carefully which diuretic, if they need a diuretic and they need DIG, we have to be very careful of which types we prescribe and why. So it gets very intricate, very detailed. It's not just one diuretic doesn't fit all, one blood pressure med does not fit all, okay? So really, really try to look through those tip sheets I made. I did my very best to make it make sense to you. As simple as I could do it. But I think they will help you if you really sit down. I would suggest on your own, I don't know if you guys do group studying, but at least initially I would suggest you sit down on your very own and absorb it with no distractions and none of this with groups, and then if you want to come back together and study, but initially you should probably just look at it yourself and absorb it. I think once you look at it, you'll realize that, okay, this is doable, okay? And it speaks of that on page 487, bottom of that. It goes through a little bit of those diuretics and how that interaction can cause the toxicity. So page 488, there's a nice little blue nursing problem for you. We'll go through that a little bit. One thing I do want to point out too, that bottom of that blue box, one thing we're going to be looking at is edema. Anything with heart issues, right? We're looking for peripheral edema. And when I say peripheral edema, what do I mean? Specifically?
Fingers.
Ankles, wrists, hands, fingers, yes. So really that can be an indication of heart failure. Now that doesn't mean everybody with swollen ankles. I had a friend text me today, oh my God, my ankles are swollen, and she showed me that lab. I think I'm in heart failure. Well, the lab readout they gave her, they just laid out what would indicate heart failure. She didn't read to the bottom to her level, which was perfect. She said, oh my God, I guess I'm in heart failure and my ankles are swollen. Well, okay, let's talk more. Well, she had been taking a bunch of ibuprofen with other meds, which was contributing to her swelling, all this salt. I'm like, your heart's perfect. So, peripheral edema does not necessarily mean it's heart failure, right? So we don't want to freak out or anything. But peripheral edema and pulmonary edema together, we don't like that, right? Our lungs should not sound wet. If you listen to somebody's lungs, and we call it pulmonary edema. Pulmonary is lungs, right? Pulmonary edema, along with peripheral edema, those could indicate some sign of heart failure being present, okay? And they note that on the bottom left of that blue box on 488. So careful patient assessment, physical assessment is really, really important with all patients, really. Sometimes they don't know they have heart failure until we discover it. So pay attention to those signs and symptoms. So digoxin assessment, baseline rate, you want to know? Always want baseline. We're always going to assess for toxicity, which is what I mentioned earlier. I think I've already gone through all this, right? You guys can read all that. We might be monitoring those levels routinely. Potassium level is super important too, because if they have hypokalemia, that
They're gonna dump
can
toxin.
be, that's correct, that can lead to DIG toxicity. So hypokalemia and DIG toxicity can go hand in hand. Very, very important. And also instruct those patients of those potential side effects. So I go a lot on DIG, right? It's important. It's just so common. We just use this a lot. So the two P's. Just remember with digoxin, what are the two P's? Pulse and potassium. Know your two P's. Don't give it less than 60, and don't give it less than 3.5 unless they tell you to go ahead and give it. So digoxin is your two P's. That helps you. How many we got? We got a lot of stuff up here. There's some, like I said, there's other agents for heart failure, which we'll get to specifically here in a little bit. ACE inhibitors. I don't know how far I want to jump into this, you guys. So are they taking a potassium sparing diuretic? We'll talk when we get to diuretics. Like I said, there's potassium wasting, there's potassium sparing. You guys are gonna need to know which is which. If they're taking a potassium sparing diuretic, what's gonna happen to their potassium level? Yeah, they're gonna spare it, the potassium level could potentially go low. If they're taking a potassium wasting, it's gonna drop. So it's those potassium wasting that we need to be careful with the digoxin, okay? And again, so ACE inhibitors in general can affect those potassium levels. So again, we'll talk more about that. Beta blockers, anything that's blocking is blocking something. If it blocks something, what's probably gonna happen? Slow it down. If you're blocking it, you're slowing it down, right? Just think about little blockers, those little football players, I think they gave you, it's gonna slow things down. Easy way to look at it, which means they could have bradycardia, lower blood pressure, all these little nuances. One thing about beta blockers, I do want you to know, cause rebound hypertension. So you do not want to abruptly stop with beta blockers. Okay, that's kind of important to know there. And again, these are, like I said, you're gonna see these interwoven through all these chapters. Your angina, I guess we only got 5 minutes. I hate to get into angina. Will somebody help me remember where we start? So page 489, angina. We'll start here. We've got next week to get through all of it. So we're gonna do what we can do. You do your drug cards, go through all those tip sheets I gave you, and then I'll see if I can somehow pull it together in a more manageable one-day event. So please look through that stuff, and that will help you guys. And I will do my very best to get your grades to you today. And we.
I would be very happy with that.
That would be very.
I think it can. I think it can. It'll probably be no promises, but I think it's gonna be by noon. I think.
I would be super happy.
I think
By
no
noon.
promises, but I.
She might give us our grades by
Today?
noon.
Yeah,
Yeah.
I'm so scared.
I am too.
Did you guys think
I am do really well on this select all, so
Yeah.
I worry about that.
I feel like I stare at them and I'm like, there's no way that
I
it's
just
just
wanna
this.
click
There
Yeah.
has to be more.
I